Well, uh, hello, everybody. I'm going to give you some information about what mechanical ventilation should be. When somebody says to a physician that the patient is dependent on a ventilator or is on mechanical ventilation, immediately the physician thinks that the patient is intubated or has a tracheostomy tube, a tube through his neck. However, you're going to learn now that there are other ways to provide ventilatory support that are non-invasive. Non-invasive interfaces are simply giving air through a mouthpiece, a nasal interface, an oral nasal interface, or something called a ventilation belt, an intermittent abdominal pressure ventilator. Well, tracheotomies, though, go back a couple thousand years. In fact, Alexander the Great performed a tracheotomy on one of his soldiers who was obstructed from croup. In 1867, there's a publication in the United States for 267 people who had tracheostomies placed because of diphtheria and croup and airway airflow obstruction. Nobody ever used it, though, to ventilate anybody's lungs, except Galen, who did this for animals in the 4th century BC, I believe. From 1930, before 1930, there was no such thing as home mechanical ventilation because there was no electricity. So from 1930 to 1956, when people got polio, muscular dystrophy, Lou Gehrig's disease, spinal cord injury, they were put in iron lungs. And some of these people got tracheostomy tubes, not to ventilate them, but to suction out airway secretions from uh, then in 1952 in Denmark, there were no iron lungs. So a physician there, Dr. Lassen, who had performed with an American pulmonologist in New York, a Dr. Cornand in 1947, intermittent positive pressure ventilation, giving medications to COPD patients through a mouthpiece and an IPPB machine. He put two and two together and decided, well, if we put a trach tube through someone's neck, we can hook that up to such a machine and ventilate the lungs. Actually, in 1898, ambu bags became available. So what happened was in 1952, they put trach tubes in many people and had 400 medical and dental students bagging the patients 24 hours a day to support their breathing until the pulsular ventilator came on the market after 4 months. Imagine having a tube through your swallowing muscles like this when you don't need it. Well, nobody needs a tracheostomy tube for only being too weak to breathe. Even if you have zero vital capacity and no muscles whatsoever above or below the neck, you do not need a tracheostomy tube for ventilatory support or for clearing your secretions. You don't. The tube causes airway secretions. When it's removed, the secretions leave and nobody needs them now. This is 1952 in Denmark. They put the trach tubes in, hooked the patients up to their pulsular ventilator, and uh, and then they created intensive care. Intensive care was created because of trach tubes. Today, because of intensive care, we get trach tubes. People get trach tubes because of intensive care, because they're in intensive care, whether they need them or not. However, in those days, intensive care was created because with trach tubes, you gave oxygen, you were suctioning, humidification, you had to change the tubes, there was bleeding, and there were major complications, mucus plugging, pneumonias, fistulas, and so on. Also, 65% of these patients get tracheal stenosis, as you can see, the closure of the upper airway. And patients die from all these things. 50% of people who get trach tubes are dead within 1 year. And 50 to 80% of people with only muscle weakness, like neuromuscular diseases and spinal cord injury, they die because of complications of the trach tube. But there's no incentive to not put trach tubes in except for the patients, and they're not told that they don't need them. Bacterial contamination causes chronic bronchitis, mucus plugging, recurrent pneumonias. Because of trach tubes, the tubes cause deconditioning of the diaphragm. And as I mentioned, more than half the people on trach ventilation die because of the tubes. Now, understand, if you've got metastatic cancer, if you've got severe traumatic brain injury or advanced ALS with upper motor neuron disease, you're likely to die within a year because of those lethal diseases. But nobody with lower motor neuron disease, spinal cord injury, neuromuscular disease, muscular dystrophy, spinal, None of these patients have lethal diseases if you just ventilate their lungs and know how to prevent respiratory complications, which physicians don't learn how to do in the United States. This was a 34-year-old school teacher. She had never walked. She has spinal muscular atrophy type 2. She was in a wheelchair all of her life, and at 34 years of age, she got a cold. But her cough flows were so poor, she couldn't cough effectively, and so she got pneumonia. She went to the local hospital, and they did to her what they do to everybody like this. They give them oxygen. Anybody with respiratory symptoms is given oxygen, even if you have no respiratory disease. Even if they're only, what you really need is air. What you need is air under pressure to give normal breaths, but that's not what is given. Oh, excuse me. Yeah, hi, I'm giving a lecture. Please call back in a half hour. Thank you. Yeah, this is what they do to all these patients, and the patients end up dying from the translaryngeal tube makes it impossible for these people to breathe. So, for example, this girl had never had a respiratory symptom or complication or problem until she got the cold and didn't have adequate airway cough flows to clear it. So when she got pneumonia, got intubated, she became too weak to breathe because of the tube. And so they trached her. And then for 3 months, they tried to wean her from the ventilator. But they couldn't wean her. She couldn't breathe for 2 minutes on her own. So they sent her home. The family raised $25,000, flew her from Santa Barbara in 2018 to University Hospital, where we took her trach tube out. And 2 months later, they drove her from Santa Barbara to San Francisco, where I was lecturing, to thank me again for removing her tracheostomy tube. How about non-invasive ventilation? Well, the Italian doctor Paracelsus in 1530 took his chimney bellows and inflated his patients who were symptomatic or short of breath. This is another ventilator, a trotting horse. When along the Thames River in London or the Seine in France, if somebody was drowned, they would put him on the back of a horse. This would not only ventilate the lungs, but also clear the secretions. I think a barrel even worked better. They roll them back and forth. Now, I never saw outcome studies on this, but they did this for hundreds of years in Europe, so, and in the United States too, I believe. In 1907, the pulmometer became available for people with smoke inhalation, asphyxia for any reason, drowning, and so on. Now, this was a air delivered via a mask that was powered by a air tank or oxygen tank, but or simply an air cylinder. And this was used until ventilators came on the market. Now, the ambu bag or the manual resuscitator was available since 1898. In 1836, iron lungs were designed, and Al Drinker here in 1929 put the first iron lungs on the British market, and then Jack Emerson in 1931 put hundreds of iron lungs on the American market, and since 1931. And when nurses had to do nursing care, they would go inside the iron lung room and take care of their patients. The Bragg Paul pulsator was the prototype intermittent abdominal pressure ventilator. I'll show you what I mean. This was 1938, and this in the 1950s was an intermittent abdominal pressure ventilator. Air from the ventilator, instead of going through the nose, the mouth, or the neck, goes to under the clothing to an air bladder inside the girdle that presses on the belly, moves the diaphragm, ventilates the lungs all day long without air going anyplace else. This was a Duchenne patient who used it for 15 years under his clothing, and a spinal cord. Oh, this is the bladder that goes inside the girdle. And in 1893 in Buffalo, Dr. George Feld demonstrated resuscitation of opium addicts by using mask ventilation with a hand-operated bellows for mask ventilation, and a pre-ambu bag type thing. And he demonstrated this through intubation, oral nasal interfaces, but he was ridiculed for this, and this was ignored for 40 years. So until the 1930s, people who went to surgery with general anesthesia, they often stopped breathing, and nobody did anything about it because they ignored Dr. Fell, who showed everybody how this could be prevented. In 1952, I told you that they started putting trach tubes in people in Denmark, also in the United States. In 1953, at Ranchos Los Amigos in Los Angeles, Dr. John Effelt pointed out that the patients didn't want trach tubes. And they took the tubing, put a mouthpiece on the end of it, and they hung it by the mouth. You just hang it by the patients and they grip it with their lips when they want it. And when they don't want it, they just let it go. It's just too simple. Well, this became the number one method of non-invasive ventilatory support from 1957. And this is my mentor, Dr. Augusta Alba at NYU Goldwater Hospital. She took the 257 patients out of iron lungs at Goldwater, gave them mouthpieces like this, and they never went back into the iron lung. And they would use it 24 hours a day. The Bantam ventilator came on the market in 1957. So the mouthpiece and tubing were attached to the ventilator, and the patients used it in the wheelchairs 24 hours a day. This is this 9-year-old girl who had polio in 1954. In 1957, Dr. Alba took her out of the iron lung, gave her a mouthpiece. She used it for 70 years. She died at the age of 79 after 70 years of 24-hour non-invasive ventilatory support. In fact, none of these Goldwater patients that I knew, and I knew hundreds of them, ever died from respiratory complications. Now, they died from metastatic cancer, from heart disease, from strokes, and so on. This is a spinal cord patient who was trached on trach ventilation 24 hours a day from 1967 to 1969. In 1969, Dr. Alba took his trach out. Excuse me. Now, during that time, those 2 years, he had had two cardiopulmonary arrests from mucus plugs in the trach tube. It caused cortical blindness. Then in 1969, after Dr. Alba took the trach tube out, for the next 38 years, he used the pneumobelt, which is what you see him doing right here during the day. This man used it for 49 years with zero vital capacity. I once took him to a pulmonary meeting in Toronto, and I said to the doctors, I said, this man has zero vital capacity for 38 years at that time. How is he breathing? Nobody could figure it out. He's got a sip and puff control motorized wheelchair. The ventilator's on the back of the chair. The tubing delivers the air under his clothing to the pneumobelt. He did this for 49 years. This is a Vosen ventilator. It's a portable ventilator, but it also has something called a cough assist, which I'm going to tell you about. Now, when nurses had to open the iron lung, they had to ventilate the lung somehow. So Jack Emerson put a dome around the head and put positive pressure in there to ventilate the lungs. I said, Jack, why don't you just give him a mouthpiece? And he said, well, we never thought of that. This lady died from a stroke after 42 years of mouthpiece ventilation, 24 hours a day. And this lady, likewise, she had a chin control motorized wheelchair, used the mouthpiece 24 hours a day for 48 years. This woman, 65 years, 24-hour mouthpiece ventilation. And she worked for 40 years as a rehabilitation counselor at Independence Care Systems in New York City. She actually died because of complications of morbid obesity. Unfortunately, she was an incredible person, just an amazing woman with many, many awards she got. This is the lip seal that people used for the mouthpiece at night after 1964, when it became available, until 1981, and I'll tell you about that. So this is the article I published with Dr. Alba in 1993 on the follow-up of the 257 patients on mouthpiece ventilation since they came out of iron lungs. Nasal ventilation was first described in the medical literature in Genesis chapter 2, verse 6 and 7, where God gave ventilatory support via Adam's nose and with that life. The next article on it, or the next time it was used, was 1981 in Poitiers, France. I went to France to teach the French about non-invasive ventilatory support, and the guy there I worked for said, well, stop ventilating them through the mouth, ventilate them through the nose. So I got Foley catheters, put them in my nostrils, inflated the cuffs, hooked myself up to a Monal D ventilator, and it ventilated my lungs very nicely. But I didn't think it would work at night because I figured all the air would leak out of my mouth. Well, in 1984, I discovered that was not the case. This was a girl with less than 200 milliliters of vital capacity with a congenital myopathy. And she did beautifully on nasal ventilatory support settings. This is not BiPAP. This is not CPAP. BiPAP came on the market in 1990, mainly because, well, I'll tell you later. But this is a non-invasive ventilatory support through the nose. There's no EPAP here. There's no expiratory pressure stopping her from exhaling. In 1987, I went to see a multiple sclerosis patient during an acute exacerbation, and she had become completely paralyzed below the neck. I asked her how she was doing. She said, Doctor, I haven't slept in 3 days because I'm so anxious. Well, her vital capacity was 250 milliliters. And then I realized I understood why she couldn't sleep. If she fell asleep, she couldn't recruit her accessory muscles and she couldn't breathe. So I put her on nasal ventilation like this from a portable ventilator, and I gave her 900 milliliters. She immediately fell asleep. I put a spirometer on the exhalation valve. She exhaled 750 milliliters into the spirometer. So she got 750 of the 900 milliliters I was delivering to her, and she never shut her mouth, never closed her mouth. So I got a flashlight. I looked through her mouth. The air was pushing the soft palate against the back of the tongue and sealing off the oral pharynx. The next morning, I went to see her. I said, How come you're still using the nasal ventilation? She said, Doctor, because I can't breathe without it. Her vital capacity the next morning was 100 milliliters. So that made me think that you could even do this with 0 milliliters. So I went to two of my patients with 0 milliliters of vital capacity. I stayed in their homes all night, watched them all night, and they never desaturated. They used nasal ventilation like her. They never desaturated, but they didn't want to switch from the mouthpiece to the nasal. But I realized that nasal ventilatory support could work even for people with no ability to breathe at all. This was a first portable volume ventilator in 1977. And this is now a ventilator that's about 6 pounds. It's called the Larissa. No, it's not Larissa. It's Lucrece. No, I forget the name of it now, but it's named after a woman that starts with an L. And it's made by the Lowenstein Company. Huh. Now, Jack Emerson's photo is above that device there. That device is called a coughlator. If you know what a cough assist is, basically it's a vacuum cleaner motor that gives you a deep breath and the pressure drops and you get 10 liters a second of expiratory flow. That's a cough assist. Now that's been on the market when I convinced Jack Emerson to put it on the market in 1992. However, the coughlator was on the market from 1952 to 1967. In 1967, they put trach tubes in everybody, and nobody ever used it, the coughlator through the trach tube until I did in 1990. At any rate, um, the cough assist that came back on the market in 1990, Jack Emerson gave me one in 1988 after I asked him for one, and we immediately started using it to clear the airway secretions of patients who were unweanable, intubated and unweanable. But since 1988, we've extubated these people to non-invasive ventilatory support and had their families use this cough assist device to clear their secretions after the extubation. We have 100% success for patients who are just too weak to breathe, even with zero vital capacity. This is a patient using the coughlator in the 1980s. Now, this patient and another one put an open letter in the newspaper. Please, somebody make this thing again. This is the only reason I don't have a tube through my neck and I'm still alive in 1988. So I took that letter in the newspaper, brought it to Jack Emerson. In 2 months, he gave me one. This is actually the article begging for someone to put this machine back on the market. In 2 months, Jack Emerson gave me his prototype inexaflator in a 5-gallon paint can, as you see right here. We immediately started using it in the critical care units to extubate unweanable people and clear their secretions. These patients don't need bronchoscopies if you use the cough assist. This is a 72-year-old woman who flew in from Warsaw to fall down her daughter's steps, break her neck, end up in our neurosurgical intensive care unit. She was intubated on Friday. I came in on Monday. We immediately extubated her, but first we used to non-invasive support. But first we used the cough assist to clear her secretions like this. I dedicated one of my first books to Mr. Emerson for putting the cough assist back on the market in 1962. Wernicke-Hoffmann's disease is a disease where before gene therapy became available, these kids would stop breathing during sleep at 5 to 8 months of age. They have no muscles below the neck or above the neck. The older boy here, I told his parents he'd be dead within 1 year without a trach tube. How do you protect your airway if you've got no muscles above or below the neck? These kids were never able to speak, never able to take any food by mouth since 4 months of age. Mom was much more intelligent than me because she got pregnant again, had a second one, who was even worse actually, 24-hour vent dependent since 3 months of age, and the other boy since 8 months of age, on nasal ventilatory support. Now they are 30 and 28 years old, been on nasal ventilation for all these years, and they don't have the one brother can open the eye slightly and move the eye, trace him out. The other brother cannot open his eye. You have to open the eye to actually move the eye and say left, right, yes, right, no, something like that. But they get free tickets to Yankee Stadium and can go when they like. And now they're 30 and 28 years old. This is another boy whose parents I said would be dead within 1 year if he didn't get trached in 1995. Now he's 32 years old with SMA type 1. Again, if you give these patients gene therapy or nusinersen in the first month of life, they almost develop normally. They get to sit, walk. They may not be able to run, but also their cough flows are never really very, very good. So I published a paper 2 years ago about three of these kids who, after $9.1 million of medications, died anyway because their physicians did not know how to use cough assists or use non-invasive ventilatory support. Because when they got sick, they got colds and they got pneumonia, just like the girl I told you about before. Why spend millions and millions of dollars on medications for each one of these kids? And then when they get sick, their doctors don't know how to keep them alive. This is literally what's happening in the United States, but not in many other places, like in South America, parts of Asia, and Europe. What is NIV? NIV is non-invasive ventilation. That has come to mean CPAP for old men and women who snore, and BiPAP at less than non-invasive ventilatory support settings. So what do I mean by that? If they do surgery on you or me and they give us a neuroparalyzing agent and general anesthesia, and you ask the anesthesiologist, how do you ventilate my lungs? They'll say, well, we give you 600 milliliters of air or 500. That creates a back pressure of 18 to 20 centimeters, or we give you 18 to 20 centimeters of water pressure. So why did they use BiPAP at 8 and 4? 8 inspiratory pressure, 4 expiratory pressure for a pressure support of 4, 8 minus 4. And then the patients fail extubation, and then they're told that they have to get trached. This is unbelievable. I saw this for 30 years. Now they've got something called volume targeted BiPAP. This is much better. You can set the volume to be adequate for ventilatory support, but most doctors who prescribe this don't set the inspiratory pressure high enough to deliver the air. So the patients don't get it anyway. Plus, the EPAP is not only not helpful, it's potentially harmful for many, many reasons. So I don't use BiPAP. I put my patients on volume or pressure cycling preset ventilatory support via portable ventilators. EPAP is harmful. Why? Because it decreases venous return to the heart, increases the risk of cardiac arrhythmias, disrupts sleep, prevents full exhalation, uncomfortable gushes of air, disturbing sleep, increases the risk of aspiration of food and reflux. It cannot be turned off, and it prevents lung volume recruitment to maintain lung health and for the patient to independently increase cough flows overnight. EPAP is not beneficial for anybody with healthy lungs and weak muscles, but the doctors use it anyway. And the insurance companies like it because it's cheaper than non-invasive ventilatory support. Non-invasive ventilatory support allows the patient to take as much of the air as the brain thinks that it needs to not be short of breath. So I write a range of about 700 to 1,500 milliliters, and the therapists go to the house and set the patient up with the volume that they want, and they use that. Or I write for pressures of 18 to 20 centimeters of water, no EPAP, no BiPAP, and from a portable ventilator. How long? Well, I've got SMA patients now. I've got 22 between 20 and 32 years old with SMA type 1 who have no muscles at all, zero vital capacity since infancy. I've got 57 Duchenne patients over age 40 and 14 over age 50. And with trach tubes, they die at the average age of 29, not 40 or 50. And without any ventilation, they die around the age of 20. The polio now for up to 69 years, ALS 14 years, and so on. Basically, you can go indefinitely on non-invasive ventilatory support. You don't need trach tubes if you're just too weak to breathe. This was a study from Japan. Before 1983, the Duchenne patients died around the age of 18. From 83 to 93, they all got trached and they died at 29.1 years of age. Since then, nobody's gotten trached and they live an extra 10 years. I just published this paper really on 486 Duchenne patients with all the patients over age 50 and 40. This is a patient who came out of an iron lung, was given a mouthpiece, and then for 21 years, he used it 24 hours a day until he died from a decubitus ulcer because he had no family, no one helping him except for attendants. When they didn't come in, he had to stay in bed and his skin deteriorated and he became septic. After 21 years of non-invasive ventilatory support. This is a 54-year-old with Duchenne, a patient with ALS, 8 years of 24-hour non-invasive ventilatory support, a spinal cord patient whose trach tube we removed in 1992. Now she's in her 50s using non-invasive ventilatory support. Morbid obesity. We took his trach out and managed him on non-invasive ventilatory support. Nobody with morbid obesity needs a trach tube because, first of all, their bulbar muscles are totally intact. They can get air at 40 or 50 centimeters of water pressure to normalize their CO2, not simply to do permissive hypercapnia and say, oh, a CO2 of 60 is normal for him. Yeah, it's normal if you want him to go into cor pulmonale and die from heart failure. A spinal cord patient who was placed in a chest shell in Pennsylvania. The chest shell is like an iron lung, but he needed a halo brace, so our neurosurgeons needed access to the chest. So I said, no problem. I showed him nasal ventilation, mouthpiece ventilation, lip seal ventilation, and we took the chest shell off. You could see the pressure ulcer on his chest. He used the mouthpiece during the day, and the neurosurgeon got the idea to tie the lip seal to the posterior poster of the brace. And that's what he did for 2 weeks. Then he came out of all that, went to rehab at Kessler, and did fine. Never got a trach, never got intubated, even though his vital capacity went down to under 700 milliliters. We had a consensus conference in the Mexican Pulmonary Society meetings in 2010, 22 centers from 18 countries, with about 800 patients on continuous non-invasive ventilatory support, all with only three diseases: SMA type 1, Duchenne muscular dystrophy, and ALS. So if you have oculomotor neuron disease, though, like CP, traumatic brain injury, or stroke, the upper airway may close so that the flows to clear the airway from the cough assist may not be adequate. And then you really need a trach tube. Or you need surgery to open the larynx to continue non-invasive ventilation. Now, that's theoretically possible, but nobody's ever done it. I published a paper 2 years ago about 13 patients who had no insurance. They were undocumented aliens, or they had no insurance. All of them were unresponsive, essentially no cognitive function, unresponsive, for months at University Hospital, costing the hospital $1,500 to $2,000 a day. So every day they had an automatic spontaneous breathing trial, which every day they failed because they breathed rapidly and the therapist thought that they could not be weaned. So Lou, my respiratory therapist, and I, there was a room with two of these guys. We did the unthinkable. We shut off the oxygen. Well, we shut off the oxygen and the saturation went below 95. And then we used the cough assist to clear the secretions, something else nobody had ever done. Gobs of garbage came out and the saturation went back to normal. Then I said to the nurses, under no circumstances put these guys back on the ventilator, assist control, until the saturation goes less than 95. Never did. Never did. Nobody ever removed their secretions, and everyone never shut off the oxygen, which was turning off the hypoxic drive to breathe and making the oximeter useless as a gauge of ventilation, airway secretions, and lung disease. Nobody ever shut off their oxygen or used the cough assist to clear their airways so that they could breathe. More than half these patients all weaned from the ventilator, but we couldn't take the trach tubes out of half of them because of the oculomotor neuron disease that didn't permit the cough assist to clear the secretions adequately. But they all weaned. If you are essentially brain dead, you've got reflexability and strength to breathe. If somebody just clears your airways and shuts off the oxygen, You can save hospitals a fortune just by knowing that principle. So you could do long-term non-invasive management. You can extubate and remove the trach tubes of people who never should have gotten them in the first place. Pulmonary function testing is useless for people with weak muscles. All of it is about lung and airways disease, except for the forced vital capacity. Now, that is okay for people who are sitting, but people don't start under breathing when they're sitting. They start it during sleep. And the PFTs don't even measure the supine vital capacity. The difference between sitting and supine should be less than 7%. But nobody even measures it. PFTs don't even do that. They're completely useless. What you need to measure, I will show you. Um, Polysomnography is also useless because you could titrate away apneas and hypopneas, but you're not resting the muscles unless you give full ventilatory support settings. So none of my patients need polysomnography if they're just too weak to breathe. We measure their end-tidal CO2, their oxygen saturation, their cough flows through this $15 peak flow meter, and their vital capacity sitting and lying down. Also, their ability to air stack, to get consecutive volumes of air, to fill their lungs with air, to see how much air we can fit into those lungs to keep them compliant. In 1998, I published a paper that if you put a patient with muscular dystrophy on oxygen, it's worse than giving him nothing at all. And anyone with a trach has more hospitalizations and pneumonias than people on 24-hour non-invasive ventilatory support. The oxygen turns off the hypoxic drive and makes the oximeter useless. There are three real respiratory muscles: inspiratory, expiratory, and the throat muscles. As the vital capacity goes down, the cough flows go down and become inadequate to clear the airways. So our goals are to maintain the compliance of the lungs by doing lung volume recruitment, to optimize cough flows, and maintain normal blood gases around the clock. This is a baby with congenital myopathy, and you see that the lungs will not grow because if you've had a baby, when they cry, their lungs expand, and that's what causes their lungs to grow. This child's lungs will not grow because he's got no chest wall muscles, and he'll be dead in a matter of weeks if you don't expand his lungs like this. Now, these brothers I showed you before, that's what they look like when they were infants. On nasal ventilation since then. Also, I teach my patients how to frog breathe. Now, frog breathing is actually using your tongue to ventilate your lungs. So I've showed you a patient before with zero vital capacity. He could breathe all day long using his tongue, not a ventilator. I had a patient who was a lawyer, 24-hour vent dependent on non-invasive support. He didn't even bring his ventilator to court because he actually frog breathed in court. This is how you do it. If you're driving in Newark, I suggest you learn this technique. You never know when it can come in handy. With zero vital capacity, if I don't have brain injury, I'll be able to ventilate my lungs all day long with no muscles below my neck by glossopharyngeal breathing. 48-year-old Duchenne using mouthpiece ventilation. We could get almost 2 liters of air into his lungs when he was 48 years old, even though his vital capacity had gone to zero and his ability to frog breathe was lost after the age of about 37. Measuring cough flows. We inflate the patient and have them cough and measure those flows. Now, also, we do what we call air stacking. This is a woman with 800 milliliters of vital capacity, 900 milliliters. She's able to frog breathe up to almost 3,000 milliliters of air. That permits her to get an effective cough overnight. And if her ventilator fails, she can use this. A man with zero vital capacity, just able to frog breathe all day long, 12 breaths, 500 milliliters of breath, just by glossopharyngeal breathing. One day he woke up to discover his ventilator was no longer functioning. He had no use of his arms or legs, no alarms on the machine, and he would have died if he didn't know how to frog breathe. Cough flows. You ought to 90% of mortality in neuromuscular disease in people with cough flows below 200 is because of pneumonia due to ineffective coughing. You need to take a deep breath to 1.5 liters. Then you create abdominal pressure, thoracoabdominal pressure, and then you open your glottis and you get an expulsive decompression of 500 liters a minute of flow, or 400. You need at least 300 to be effective. So we press on the belly, and this increases the cough flows. And cough flows that are ineffective, if you give them a deep breath or a deep volume of air and press on the belly, they become effective and can prevent pneumonias. Now, the cough assist Jack put it on the market, Jack Emerson, in 1992. Now there are 10 companies that make this in about 9 different countries. You got to use it at 50 to 60 centimeters of water pressure, not 40 or less. And through tubes, you use 60 to 70 centimeters of water pressure. The third goal is to maintain normal ventilation. And I've already told you, morning headaches, fatigue, sleepiness are signs of hypercapnia during sleep. These patients with weak muscles need non-invasive ventilatory support, not BiPAP, not CPAP. And infants sweat. They have paradox. Any infant with paradoxical breathing needs to be on nasal non-invasive ventilatory support to reverse the paradoxing. Otherwise, their lungs will not grow. So we set the volumes and we send the therapist to the house to find what settings the patient wants to use. And the diaphragm, when the vital capacity is low, is like this weak horse. If you don't rest it, it collapses. The ventilator is like a pickup truck that you rest your muscles overnight, which you don't do by using a BiPAP at a pressure support of 8 or 4. And then you're able to go all day much better with more energy and so on. This is the Louisa. I remember her name now. The name of this ventilator by Lowenstein is the Louisa. There are people who can walk with essentially normal muscle strength who cannot breathe because they're too weak to breathe. This is an example of one such patient. He was an accountant. He had Milroy's disease. He had failed many extubation attempts, and he got trached. So we removed his trach and then switched him to non-invasive ventilatory support. But he needed it around the clock, even after we took his trach out. He had 7 ventilators, 3 at home, 3 at work, and 1 in the car. And in the car, he'd use mouthpiece ventilation while he's driving. The police would stop him thinking it was a hookah pipe. He worked for 15 years like this before he died from his primary disease. This man was in an explosion that destroyed his lungs. He was DNR and in agonal breathing. He was dying with a high CO2. He refused to be intubated or trached. So the pulmonologist said, yeah, you can try non-invasive ventilation. And we did. We put him on nasal ventilation. He woke up, he went home for 11 months and then died at home. So he had 11 months of extra life because of non-invasive ventilatory support. We tell our patients to use the oximeter as feedback to keep the saturation normal when you're sick. So if it goes below 95, it's got to be either hypercapnia, airway secretions, and if you don't get them out, you end up with atelectasis or pneumonia. So that's how they do it and avoid pneumonias. Now, extubation and decannulation. The people are not extubated unless they're thought to be weaned from the ventilator with adequate cough, few secretions, low pressure support need, etc. And this is nonsense. Patients with zero vital capacity can be extubated 100% of the time to non-invasive ventilatory support. Our criteria are basically a normal oxygen saturation of room air. And we get it normal by using the cough assist through the tube until the saturation is normal in room air. Now that can take 2 or 3 days, sometimes even longer. But once the saturation is normal in room air and the patient is fully alert, we extubate them to non-invasive support. This was the first time the prototype cough assist was used in critical care for that Polish patient with C2 partial tetraplegia with under 200 milliliters of vital capacity. We cleared the secretions. We extubated her on Monday, cleared the secretions, and she did fine. This is an SMA type 1 child who was hospitalized for pneumonias 5 times from the age of 4 to 9. Because she was 24-hour vent dependent and used the cough assist for every cold, her next cold was when she was 15. Now, her SATs were low. We normalized them by using the cough assist through the translaryngeal tube. She was intubated for over a week. And then when her SATs were normal, the therapist and I stood at the foot of the bed and said, we've done enough work, Homa. That's her mother. You extubate your daughter. So we gave her a syringe, took the air out of the cuff, pulled out the tube, used the cough assist and bagged her and put her on nasal ventilation in 7 seconds. This is actually her mother's arm taking care of her after she extubated her. And the point is that even with zero vital capacity, it's easy to extubate somebody if you prepare them properly for extubation by clearing their airways by using the cough assist, otherwise known as mechanical inexsufflation. Now, this girl, by the way, is 31 years old with SMA type 1. And now, this patient, we extubated her with her vital capacity under 200 milliliters, and we showed her mouthpiece ventilation, lip seal ventilation. Now, I told the nurses I wanted her to use a lip seal to hold the mouthpiece in place overnight. So they called me at 3 o'clock in the morning and they said, well, the patient's not using the lip seal. So I said, well, what's her oxygen saturation? What's 98% in room air because none of my patients get oxygen. And I said, well, why are you calling me? She's in an intensive care unit. She's getting all the air, you know. The next day I come in to see her and she was sleeping with the mouthpiece, not leaking at all, with a normal saturation. So I took a video of it just to show people how between 1952 and 1957, before portable ventilators became available, people used the mouthpiece like this day and night. And they never lost the mouthpiece because even fast asleep, their lower brain was intact and functioning and knew that if they lost that mouthpiece, they would die. That's how effective the lower brain is at preventing these things. This is the other patient who's 32 now, SMA1 kids. There, I showed you them before. We took the trach tube out of this SMA1 patient at 28 years of age with zero vital capacity and put him back on nasal ventilation. This is a new mask that we use to extubate people also. This is a girl with a congenital myopathy who was unweanable. She was transferred to us to be extubated at 3 years of age and at 27 years of age from Robert Woods Johnson Hospital, where they don't use non-invasive ventilatory support. But she was intubated there. She didn't want a trach, so she got transferred to us those two times, and we extubated her without putting a tube through her neck. And there she was later on. We published 157 of these cases in chest in 2010, another 100 in respiratory care 5 years later. The diagnoses are ALS, Duchenne, ICU myopathy, multiple muscular dystrophy, myasthenia gravis, polio, spinal muscular atrophy, spinal cord agent, and other neuromuscular disease. We also take the trach tubes out of patients. In 1990, I published these two papers on 100 high-level spinal cord patients whose trach tubes we removed to non-invasive ventilatory support so they could learn how to frog breathe, so they wouldn't have to worry about accidentally get disconnected or the ventilator failing, and they could be much more safe without the trach tube than with it, even for a C2 quadriplegic. And I told you about this girl. We took her trach out after she was flown here for $25,000 from Santa Barbara. We extubated her. We removed her trach tube to nasal ventilatory support. 2 months later in San Francisco, they drove her up to thank me again. This is a woman who was in her 50s with a limb girdle muscular dystrophy in a hospital in New York for 6 months. She was living in an Hindu ashram where they were not permitted to suction her trach tube. So they tried to wean her for 6 months. They couldn't do it. So they sent her to me. We extubated her the day she arrived on a Friday afternoon, sent her home on Tuesday without a trach. An ALS patient on trach ventilation for 2 years. We removed the trach. Now she was non-bulbar. We put a cane tip over the ostomy, plant it there, and it closes within 3 days, usually, sometimes up to 2 months. Another man whose trach tube we removed, he got a trach. The next week he came to our clinic and we took it out immediately. He never needed to get the trach. He was on non-invasive ventilation for 15 years. He goes to a hospital in the Bronx where they give him oxygen. They become comatose. They tell the family he needs a trach. They believe him. And then the next week he came to us, we took the tube out. I won't talk much about money here, but well, let me tell you that the population of the United States and the number of doctors has increased by 50% in the last 50 years. Medical administrators and bureaucrats over 3,000%. And these are all the people who work for the insurance companies who make money off of your work and my work. We spent $6 trillion for healthcare last year, 6 times more than for our military. China spent 1 trillion for healthcare of 1.5 million people, and the life expectancies are the same in both countries. So this country is not run well, to put it mildly. I know how to save $4 trillion a year and improve American healthcare. To be like, I worked and lectured in the number one and number six healthcare systems in the world. One of them cost the government less than 2% of GDP, as opposed to 19% of GDP for Americans. And they live 6 years longer than us and are rated in the top six. And I know how to do it, but nobody cares because everyone's got investments in insurance companies and making money. And you make so much money by putting tubes in people's necks. Not just the doctors, but the hospitals, the LTACs, the long-term acute care, the nursing facilities, the nursing agencies. Everybody makes a fortune on Medicaid. 65% of these patients are on Medicaid, costing taxpayers $440,000 a year for each one. And you wonder why our debt is $41 trillion? I know why. I know how to balance the budget and how to improve medicine. I tried to contact the bureaucrats in Washington. Nobody gives a damn. Nobody cares because they're all profiting from the system the way it is until we crash. But we paid over $1 trillion of our 2.4 trillion in tax dollars on the interest on the federal debt, and the debt is increasing by $1 trillion every 3 months. Soon, more than half of our income tax will be going to pay interest on the debt, and there won't be any money for anything else. And that's what we're headed for. This is a website for anybody who has weak muscles and needs some help. This is my non-respiratory book. It's only $20, but it's cardiac muscle management, therapy, robotics, orthopedic management, everything, except basically respiratory. This is my last book, my 15th book on non-invasive ventilatory support. It was translated into Spanish as fast as I could write it. In fact, next week I'm going to be lecturing at two universities in Chile. Um, and um, and I think that was it. So when they tell you that the patient needs a tracheostomy tube, consider it a little more deeply. If it's only for muscle weakness, they don't need it. But the only in drbach.com, you'll see the centers that do what we do. There are none in the United States. There used to be one in Dallas, but the doctor there retired. There are no others that I know of that do what we do for children and adults. No trach tubes, even with zero vital capacity. There are three centers in Mexico. There are a number of them in Argentina, Paraguay, Uruguay, Chile, and Spain. Anyway, that's American medicine for you. Let's hope that somebody takes an interest in improving it and saving 4 trillion a year before nobody will tell them that. All right. Thank you. Thank you very much. By the way, my office is in the Behavioral Health Science Building on F level, 1559, if anybody's interested in learning more about these ideas. You won't learn them in medical school or anywhere else. I got to try to stop this recording. Let me see. I don't know how to do that.